Welcome to the deep dive. Get ready to plunge with us into a truly intricate world, the hidden machinery of your kidneys and, well, how we interact with it, especially when things go wrong.
It's definitely a journey. It takes us deep into fundamental physiology, right down to the molecular level of how drugs work and, the major health challenges faced globally.
Absolutely. Our source material for this deep dive is pretty dense, a detailed text that lays it all out from the specific mechanisms of different diuretic classes.
All the way to the distinct ways kidney injury shows up, acute versus chronic.
The specific diseases that target different structures within the kidney, and even the complex realities of treatments like dialysis.
Right. And our mission today, really, for you, is to pull back the curtain on all of it, to walk through every key concept, every important detail mentioned in these pages.
Yeah, aiming for that level of thorough understanding that really feels like mastery, like you've specialized in this specific material.
Think of it as your accelerated path to truly knowing this stuff.
Let's dive right in then, starting with the tools we use to manipulate kidney function diuretics. In the simplest terms, these are substances that make you produce more urine.
Right. And the fundamental way they do this, the source really emphasizes, is by decreasing the reabsorption of sodium by the kidney tubules.
Okay, so if sodium isn't pulled back into the body as much, it stays in the tubular fluid.
Exactly. This increased sodium output is called natriuresis. And here's the key, that sodium acts like an osmotic force, basically holding water with it in the tubule.
So decreased sodium reabsorption automatically leads to increased water output, or diuresis. It's all driven by that sodium movement.
Precisely. And blocking sodium reabsorption in different parts of the nephron has ripple effects. Depending on where it happens, it can influence the reabsorption or excretion of other critical solutes like potassium, chloride, magnesium, calcium.
So the main clinical reason we use these drugs, is it mostly about reducing extracellular fluid volume?
Yeah, that's the primary goal, the fluid outside your cells. This is huge for conditions like edema, where you have excess fluid buildup or hypertension, high blood pressure.
Because sodium is the main determinant of ECF volume, right? So
Yeah.
targeting its reabsorption is the direct path.
Exactly, shrinking that volume. And acutely, the effects can be really dramatic. The source notes some diuretics can increase urine output by more than 20 times the normal rate shortly after you take them.
Wow. But here's where the body's resilience or maybe stubbornness comes in. That massive initial increase doesn't last forever, does it?
No, within a few days, your body starts to compensate.
How does that work?
Well, as ECF volume drops, your arterial pressure tends to fall, GFR might decrease slightly, and crucially, systems like the renin-angiotensin-aldosterone system, they kick into gear.
Right.
You get increased renin secretion, leading to more angiotensin II.
So the body senses the volume depletion and tries to conserve fluid, like fight back.
Yes. These responses work to increase sodium and water reabsorption elsewhere in the kidney, eventually kind of overriding the chronic diuretic effect on urine output itself.
So what's the end result then?
You reach a new steady state, urine output matches fluid intake again, but, and this is the key, you've successfully reduced your ECF volume and, often, your arterial pressure. That's the therapeutic win.
It's fascinating how this system finds that new equilibrium. Now, the text makes it clear diuretics aren't just one thing. They have diverse mechanisms, and importantly, they work at different specific sites along the nephron.
Absolutely essential to understand these different targets. This is where the mastery really starts to build, understanding where they hit. Let's break down the major classes mentioned in the source.
Okay, first up, osmotic diuretics, like mannitol.
Mannitol is a classic example. The elegant mechanism here is pretty simple. These substances are freely filtered by the glomerulus,
Okay.
but then they are not significantly reabsorbed by the tubules.
So they just stay in there.
They stay in the tubular fluid in high concentration, and that dramatically increases the osmotic pressure within the tubule. This osmotic force then literally pulls water into the tubule, or, maybe better said, prevents its reabsorption.
Leading to more fluid being flushed out.
Exactly, more urine.
This reminds me of something the source uses as a really powerful example, uncontrolled diabetes mellitus. When blood glucose is sky high,
Yeah.
it gets filtered, but exceeds the kidney's reabsorption limit, the transport maximum.
Precisely. That excess glucose left in the tubules acts exactly like an osmotic diuretic. It's the same principle.
And that explains why uncontrolled diabetics have polyuria, that frequent excessive urination. The sugar's just pulling water out.
And the polyuria leads to secondary polydipsia, that extreme thirst. It's a direct consequence of that osmotic effect, a perfect real-world illustration.
Okay, so moving on to arguably the most powerful class, the loop diuretics. Names like furosemide, ethacrynic acid, bumetanide.
Heavy hitters.
Yeah. Where do these guys do their work?
Their main target is the thick ascending loop of Henle. They block a key transport protein on the luminal side, the inner side of the tubular cells there. It's called the NIC2Cl co-transporter.
K2Cl. So they stop the reabsorption of those 3 ions right there.
Correct.
And the source explains 2 critical reasons why this leads to such massive diuresis.
Right. First, blocking absorption in the loop means a much larger load of sodium and other solutes gets delivered downstream to the distal parts of the nephron.
Okay.
And just like the osmotic diuretics, these excess solutes hanging out in the tubule act osmotically, preventing water reabsorption later on.
And second, this sounds crucial for understanding kidney function. They wreck the countercurrent multiplier system.
They do, big time. By preventing the reabsorption of ions from the loop into the medullary interstitium, the tissue deep in the kidney, they reduce the osmotic concentration gradient in the renal medulla.
And that medullary gradient is what normally draws water out of the collecting ducts, right? So reducing it means the kidney loses its ability to concentrate the urine effectively.
Exactly. The source really emphasizes that loop diuretics impair both the ability to concentrate and dilute urine. Impaired concentration is due to the reduced medullary osmolarity.
And the dilution.
Impaired dilution happens because blocking ion reabsorption in the loop means more ions are excreted, preventing the urine from becoming very dilute like it normally could.
The impact sounds huge.
Yeah.
The source says they can cause 20–30% of the filtered fluid to end up as urine, potentially increasing acute output up to 25 times normal.
That's right. That's why they're used when you need rapid, significant fluid removal. Think heart failure exacerbations.
Makes sense. Okay, moving a bit further downstream to the early distal tubule, we find the thiazide diuretics, like chlorothiazide.
These block a different transporter in that segment.
Which one?
They target the sodium chloride co-transporter, again on the luminal membrane of the early distal tubule cells.
The source notes their effect is significant, causing about 5–10% of the glomerular filtrate to pass into the urine.
Which lines up pretty well with the amount of sodium normally reabsorbed in that specific segment. Still effective, widely used for hypertension, but generally less potent than the loop diuretics.
Got it. Next class. Carbonic anhydrase inhibitors, like acetazolamide.
This sounds like it targets an enzyme rather than a transporter directly.
It does. Carbonic anhydrase is key for bicarbonate reabsorption, especially up in the proximal tubule.
That's right. So inhibiting this enzyme disrupts bicarbonate reabsorption. And because hydrogen ion secretion and bicarbonate reabsorption in the proximal tubule are intimately linked to sodium reabsorption.
How so?
Via a sodium-hydrogen countertransporter. So blocking bicarbonate reabsorption also reduces sodium reabsorption.
Ah, okay. So sodium and bicarbonate stick around in the tubule, draw water with them osmotically, acting as a diuretic.
Yep. The trade-off, as the source points out, is that losing all that bicarbonate in the urine can lead to metabolic acidosis. So that's a potential downside.
Right. Now, 2 classes that work further down in the collecting tubule and duct, and these are different because they have specific effects on potassium. First, mineralocorticoid receptor antagonists.
Like spironolactone and eplerenone.
How do they work?
These drugs compete with aldosterone for its receptor sites in the collecting tubule and duct cells. Aldosterone normally stimulates sodium reabsorption and potassium secretion in these segments.
So by blocking aldosterone, these drugs decrease sodium reabsorption.
But leading to osmotic diuresis.
But the critical difference is they decrease potassium secretion.
Exactly. While most other diuretics tend to make you lose potassium, these decrease potassium excretion by blocking aldosterone's effect. That's why they're called potassium-sparing diuretics.
Makes sense. But there's a catch.
The flip side, which the source warns about, is the risk of too much potassium buildup in the blood, hyperkalemia. That's a key side effect to watch for.
Definitely. Okay, working in a similar location with a similar potassium-sparing effect are the sodium channel blockers, like triamterene and amiloride.
They also inhibit sodium reabsorption and potassium secretion in the collecting tubules.
But their mechanism is different from blocking aldosterone, right?
Yes, completely different target. They directly block the entry of sodium into the epithelial sodium channels, the ENAC channels, on the luminal membrane of the collecting tubule cells.
So blocking sodium entry there, How does that spare potassium?
It has a downstream effect on the NAK ATPase pump on the other side of the cell, the basolateral side. Less sodium entering the cell means less sodium needs to be pumped out by that pump.
Okay.
So the pump slows down, and since that pump normally brings potassium into the cell from the blood side, and that intracellular potassium is then secreted into the tubule.
Slowing the pump reduces potassium secretion into the tubular fluid. Got it.
Right. Different mechanism, same net effect, decreased urinary potassium excretion, making them potassium-sparing diuretics, just like spironolactone.
It's really a complex interplay of transporters, enzymes, hormones, just within the world of diuretics.
It really is.
Yeah.
And understanding that complexity becomes absolutely essential when we turn to kidney diseases, which, as the source highlights, are major global causes of death and disability.
Yeah, the numbers are staggering. Thinking about the U.S. alone, the source says over 14% of adults have chronic kidney disease.
It's often a silent epidemic for many until the later stages.
The text simplifies severe kidney problems into two big buckets.
Right. You've got acute kidney injury, or AKI. That's a sudden, abrupt loss of function over days. A severe form is acute renal failure, often needing dialysis, but thankfully recovery is possible sometimes.
And then there's chronic kidney disease, CKD. That's a progressive loss of nephron function that unfolds slowly over months or years.
And a key insight from the source is that different diseases often target specific structures within the kidney. Maybe it's the blood vessels supplying the kidney?
Or the filtering units themselves, the glomeruli,
Or the reabsorbing tubes, the tubules.
the tissue between them, the interstitium.
Or even the plumbing outside the kidney, the lower urinary tract.
Okay, let's zero in on AKI first. The causes seem to fall into three main categories based on where the problem originates.
Prerenal, intrarenal, and postrenal. Prerenal meaning the problem is before the kidney.
This is usually about decreased blood supply to the kidneys, right? They're incredibly blood hungry. Need about 1,100 mil and like 20–25% of your entire cardiac output.
Just to maintain that high glomerular filtration rate, the GFR, if that flow drops significantly, GFR plummets.
Which leads to less urine output, oliguria, or maybe no urine at all, anuria.
Right, and this causes accumulation of water and waste products.
The kidney can actually tolerate some reduced flow, though, down to about 20–25% of normal.
Yeah, because lower GFR means less filtering and less sodium reabsorption work, so less oxygen is needed by the cells. They can kind of downshift.
But below that threshold.
Below that, the cells become starved for oxygen hypoxic, and prolonged severe ischemia causes injury or death, particularly to the delicate tubular epithelial cells.
And the source makes a crucial point. Prolonged prerenal AKI can actually become intrarenal AKI if that cell damage occurs.
Definitely. What causes this reduced flow? The text lists things like severe bleeding, hemorrhage,
Extreme dehydration from diarrhea, vomiting, burns,
heart failure, where the pump just isn't strong enough.
widespread vasodilation in severe infections or shock, sepsis, anaphylaxis.
And even blockages in the renal arteries themselves, like stenosis or an embolism.
Okay, so that's prerenal. Next, intrarenal AKI, the problem, is inside the kidney tissue itself.
Right. This involves damage to the glomerular capillaries, or small blood vessels, the tubular epithelium lining the tubules, or the interstitium, the tissue in between.
And the source highlights that these structures are interdependent. Damage in one area can injure another.
Yeah, it's all connected. Examples here, straight from the source, include small vessel or glomerular injury from things like vasculitis or acute glomerulonephritis.
Widespread tubular epithelial cell death, called acute tubular necrosis, which can be due to ischemia or toxins.
And interstitial damage from severe infection, acute pyelonephritis, or even allergic reactions, allergic interstitial nephritis.
Let's look closer at a couple of those. Acute glomerulonephritis. That's a classic example of intrarenal AKI involving the filters, the glomeruli.
Typically, this is an abnormal immune reaction. Often it flares up 1 to 3 weeks after an infection elsewhere in the body, famously after certain strains of group Stinpart, A. beta streptococci.
Like strep throat.
Exactly, strep throat, tonsillitis, sometimes skin infections.
So it's not the bacteria themselves in the kidney causing the damage, it's your body's response.
Precisely. Antibodies your body makes against the strep antigen form immune complexes. These antibody-antigen clumps circulate and get trapped in the tiny filters of the glomeruli, particularly the basement membrane.
And that triggers inflammation.
Yes. This deposition triggers an inflammatory response that damages the glomeruli. The text describes glomerular cells multiplying, white blood cells getting stuck, and the glomeruli becoming blocked.
The ones that aren't blocked.
They often become leaky, letting large proteins and even red blood cells spill into the filtrate into the urine. In severe cases, you get widespread blockage and kidney shutdown.
What's the prognosis usually?
The good news is the inflammation often resolves in about 2 weeks, and function can recover over months. The bad news is that some cases cause permanent, irreversible scarring and damage, potentially leading to chronic kidney disease down the line.
Okay. Another major intrarenal cause you mentioned. Acute tubular necrosis. Literally the death of the cells lining the kidney tubules.
Right. This can happen in two main ways mentioned. First, severe ischemia. Just like in prerenal, if the blood flow is inadequate for too long, it deprives these metabolically active cells of oxygen and nutrients, causing widespread damage and destruction.
And these dead cells, they slew off.
They slow off and can actually plug up the nephrons, the tubules, preventing urine from flowing through. Even if blood flow is eventually restored, the kidney might not make urine if the tubules are plugged.
And this is a common outcome if prerenal causes progress to circulatory shock.
Yes, very common. The second major cause of tubular necrosis is toxins or certain medications.
Well-
The source lists a scary variety: carbon tetrachloride, heavy metals like mercury or lead, ethylene glycol that's antifreeze,
Yeah,
insecticides, and even some antibiotics like tetracyclines or chemotherapy drugs like cisplatin.
they have a direct toxic effect on the tubular cells, killing them.
Exactly. And again, the dead cells slough off and can plug the tubules.
Is recovery possible here?
It depends. If the basement membrane of the tubule, the scaffolding the cells sit on, remains intact, new epithelial cells can grow back along it, allowing for repair and recovery, usually within 10-20 days. But if the basement membrane itself is destroyed by the toxin or ischemia, recovery is much less likely.
Okay. Finally, the third category of AKI, postrenal.
This means the problem is an obstruction after the kidney itself. Somewhere in the urinary collecting system could be the calyces inside the kidney, down the ureters, the bladder, or the urethra.
So the kidney starts out fine, but the plumbing is blocked.
Exactly. Now, if the obstruction is only in one ureter, say from a kidney stone on one side, the other kidney can usually compensate completely, and you won't necessarily get AKI in terms of overall body function.
But if it's bilateral blocking both ureters, or if you only have one functioning kidney to begin with, maybe a transplant, and its collecting system is blocked.
Then you get AKI.
And the source notes, this is often reversible if cleared quickly, within hours.
Yes, but if the obstruction is chronic, lasting days or weeks, the back pressure can cause irreversible damage to the kidney tissue itself.
What causes these blockages typically?
Common culprits listed include large kidney stones or blood clots blocking both ureters or the renal pelvises, or obstructions lower down like an enlarged prostate blocking bladder outflow, or maybe strictures in the urethra. Kidney stones, calcium, urate, cysteine are very common causes overall.
So regardless of whether the cause is prerenal, intrarenal, or postrenal, AKI leads to a cascade of serious physiological effects.
Absolutely. The fundamental issue is the kidney's failure to remove waste and regulate fluid and electrolytes. This leads to retention of water, metabolic byproducts, and electrolytes in the blood and extracellular fluid.
Which translates to water and salt overload,
Hmm.
potentially causing edema and hypertension.
Yes, but the most immediately dangerous consequence, the source really emphasizes, is often the excessive retention of potassium hyperkalemia.
Why is that so dangerous?
If plasma potassium levels climb too high, particularly over 8 millieql or so, it can cause fatal heart rhythm disturbances, cardiac arrest.
Okay, that's critical. And what about acid?
The kidneys also fail to excrete the acid your body produces daily from metabolism. This leads to metabolic acidosis. This can be lethal on its own or significantly worsen the risk from hyperkalemia.
The source puts a stark timeline on it and severe anuria, no urine output.
Death can occur within 8-14 days without either restoring kidney function or using an artificial kidney dialysis.
Which brings us to the longer game, chronic kidney disease, or CKD.
Right. Defined as kidney damage or decreased function that lasts for 3 months or more. Typically, it involves a progressive, irreversible loss of nephron function.
A crucial point to grasp, though, is that you can lose a lot of nephrons before you feel seriously ill. The source says symptoms often don't become severe until 70–75% of nephron function is gone.
It's remarkable. You can maintain a relatively normal internal environment with as little as 20–25% function remaining because the remaining parts compensate so well.
Yeah, it's amazing how they adapt. The source lists a wide range of initial causes that can lead to CKD metabolic issues like diabetes and obesity, chronic hypertension.
Vascular problems, immune system diseases like glomerulonephritis, chronic infections like pyelonephritis.
Specific tubular disorders, chronic obstruction, even congenital conditions. So diverse origins, but they all end up leading to the same fundamental problem: a reduced number of functioning nephrons.
And this sets up what the source calls the vicious cycle leading to end-stage renal disease, ESRD.
ESRD meaning function is so low you need dialysis or a transplant just to live.
Exactly. The cycle starts with the initial nephron loss, whatever the cause. The surviving nephrons, as we said, are like superheroes. They undergo adaptive changes. They get bigger, hypertrophy,
Okay.
and they increase their blood flow, their GFR, and their urine output per nephron. Each one is working overtime, picking up the slack.
So that allows you to maintain relatively normal excretion levels even with significant nephron loss. It's an incredible adaptation.
It is, but, and this is where the vicious part comes in over years, this increased workload, particularly the increased pressure and stretch within the surviving glomeruli.
Driven by vasodilation, trying to increase flow, and often compounded by high blood pressure.
Right. This constant strain begins to injure them.
So the very adaptation that saved you initially eventually damages the rescuers.
Oh.
Kind of cruel.
It really is. This injury leads to sclerosis, basically. Fibrous scar tissue replacing the normal glomerular structure.
And sclerosis obliterates those glomeruli, further reducing the number of functional nephrons.
Which puts even more strain on the remaining ones, accelerating the cycle.
A slow-motion train wreck, heading towards ESRD.
Pretty much. The source notes that the single most effective way known to slow this progression is controlling arterial pressure, and specifically reducing pressure within the glomeruli, often using medications like ACE inhibitors or angiotensin II receptor antagonists, which target that RAAS system.
Now, looking at the real-world impact, the source lists the most common causes of ESRD. What are they?
Diabetes mellitus leads the pack, responsible for about 45% of cases.
Wow, nearly half.
Followed by hypertension at 27%, and then glomerulonephritis at about 8%.
So together, diabetes and hypertension account for over 70% of ESRD cases. That's huge.
It really is. And the source explicitly highlights obesity as a major risk factor for both type 2 diabetes and hypertension, noting its potential to add to or worsen kidney function decline synergistically.
Understanding how different types of injury contribute to CKD is key. Injury to renal blood vessels seems like a major pathway.
Definitely. Vascular lesions can cause ischemia and tissue death. We're talking about atherosclerosis, hardening of the arteries and the larger renal arteries.
Fibromuscular hyperplasia, another condition affecting medium arteries.
And nephrosclerosis, which affects the smaller interlobular arteries and the afferent arterioles, the tiny vessels leading into the glomeruli.
Atherosclerosis, or fibromuscular hyperplasia, can often affect one kidney more than the other.
Yes, leading to unilateral function loss and potentially causing hypertension, kind of like the experimental Goldblatt hypertension model where you clamped one renal artery.
What about this nephrosclerosis? The source says benign nephrosclerosis is incredibly common, seen in over 70% of people over 60.
Right. It's characterized by plasma proteins leaking through the vessel lining, leading to fibrinoid deposits, thickening of the vessel walls, and eventual constriction or occlusion.
And since there's little backup blood supply in the kidney,
This leads to nephron destruction and replacement by fibrous tissue. When it affects the glomeruli, it's called glomerulosclerosis.
the source reminds us that some degree of nephrosclerosis and glomerulosclerosis is actually a normal part of aging. Starts after 40, contributes to about a 10% nephron loss per decade.
Yeah, and that decrease in nephrons leads to a gradual decrease in renal blood flow and GFR, maybe 40–50% lower by age 80, even in otherwise healthy people.
But this process is dramatically accelerated by hypertension or diabetes.
Absolutely. Severe hypertension combined with this underlying benign nephrosclerosis can trigger a rapidly progressing form called malignant nephrosclerosis with extensive fibrinoid deposits and severe ischemia.
This source also points out a complex observation about higher incidence in Black individuals.
Yes, it notes a higher incidence of malignant nephrosclerosis and severe glomerulosclerosis in Black individuals compared to white individuals with similar blood pressure and diabetes severity. The reasons are likely multifactorial and complex.
Okay, what about direct injury to the filters themselves, the glomeruli, leading to CKD, chronic glomerulonephritis?
This is a slowly progressive disease, distinct from the acute form we discussed earlier, leading eventually to irreversible renal failure. It can be a continuation of the acute form or secondary to systemic autoimmune diseases like lupus.
The mechanism is similar in principle, immune complexes.
Often, yes. Accumulation of antigen-antibody complexes in the glomerular membrane over time, though maybe not always the same ones as in acute post-strep cases.
And this leads to chronic inflammation.
Chronic inflammation, progressive thickening of the membrane, and ultimately invasion by fibrous tissue, scarring.
The consequence being a greatly reduced glomerular capillary filtration coefficient.
Yeah,
Fewer capillaries working, and the membranes are thick and scarred.
exactly. In the final stages, glomeruli are completely replaced by scar tissue and simply can't filter blood anymore.
Okay, injury to the tissue between the tubules and vessels, the renal interstitium, also causes CKD interstitial nephritis.
Right. This can be primary damage to the interstitium itself from toxins or drugs, or secondary damage spilling over from vascular, glomerular, or tubular problems.
And infection is a big cause here.
A common cause detailed is pyelonephritis, which is a bacterial infection of the kidney, most often caused by E. coli ascending from the lower urinary tract, like the bladder.
How does it get up there?
Factors that interfere with the normal flushing of bacteria from the bladder, like incomplete emptying, leaving residual urine, or some kind of outflow obstruction, allow bacteria to multiply, causing bladder inflammation, cystitis.
And then?
A critical contributing factor mentioned is vesicoreteral reflux. This is a condition where the valve mechanism where the ureter enters the bladder fails. During urination, urine and any bacteria in it get pushed back up the ureters towards the kidneys.
Carrying the infection upwards.
Exactly. Pyelonephritis often starts in the renal medulla, the inner part, initially impairing its function, particularly the countercurrent mechanism needed for concentrating urine. So, inability to concentrate urine might be an early sign.
And if it becomes chronic?
Long-standing or recurrent infections cause bacteria to invade and damage the interstitial tissue, tubules, and eventually other structures like glomeruli, leading to widespread loss of functional tissue and ultimately CKD.
Finally, this source describes nephrotic syndrome. What's the defining feature here?
The defining characteristic is losing large quantities of plasma proteins, especially albumin, in the urine. It can happen on its own, but is often associated with other causes of CKD that damage the glomeruli.
So the underlying issue is dramatically increased permeability of the glomerular membrane. The filter becomes too leaky.
Exactly. Diseases causing this include chronic glomerulonephritis, amyloidosis, where abnormal protein deposits damage the basement membrane, and a specific condition called minimal change nephrotic syndrome.
Minimal change disease. That sounds intriguing. Why minimal change?
Because on routine light microscopy, the glomeruli look almost normal. It's fascinating. The source links it to an abnormal immune response involving T-cell cytokines that injure the podocytes, those specialized cells wrapping around the glomerular capillaries.
And that injury increases permeability, especially to albumin.
Yes. It's more common in young children, typically 2 to 6 years old, and the severity is striking. The source says a child can lose up to 40 grams of protein a day.
40 grams? That must have huge consequences.
Oh, absolutely. That much protein loss causes plasma protein concentration, especially albumin, to plummet to extremely low levels, say below 2 GDL. This drastically reduces the plasma colloid osmotic pressure from its normal 28 mmHg down to perhaps less than 10 mmHg.
And with such low osmotic pressure holding fluid in the blood vessels.
Fluid leaks uncontrollably out of the capillaries into the interstitial space throughout the entire body, causing severe generalized edema. It's a really dramatic consequence of damage at the microscopic level of the glomerular filter.
It certainly is. So, circling back to how the remaining nephrons cope in CKD, we mentioned they can maintain near-normal fluid and electrolyte balance until late stage. But how do they handle waste products and manage volume day to day?
Well, as we discussed, the surviving nephrons massively increase their activity. The source says with even up to 75–80% loss, you can still excrete normal amounts of water and electrolytes if intake is controlled and the adaptation is complete.
But waste products like urea and creatinine start accumulating much sooner.
Yes, the source highlights that their plasma concentrations rise almost in direct proportion to the degree of nephron loss.
Why the difference compared to salt and water?
Because urea and creatinine rely heavily on glomerular filtration for their excretion and aren't significantly reabsorbed by the tubules. Creatinine not at all, urea only partially. If GFR drops by half, you basically need twice the plasma concentration to push the same amount out through the remaining filters to match production.
So elevated urea and creatinine aren't just waste. They're a key indicator, a measure of how much filtering capacity you've lost.
Exactly. The source points out that measuring blood urea nitrogen, BUN, and creatinine is a primary way clinicians assess CKD severity.
Okay. What about other solutes like phosphate, urate, and hydrogen ions?
Their plasma concentrations also rise as CKD progresses, but typically not significantly until GFR drops below 20–30% of normal. The kidneys have better adaptive mechanisms for these earlier on, reducing tubular reabsorption or increasing secretion.
And for sodium and chloride, it's even more remarkable.
Right.
Plasma concentrations can be maintained almost constant, even with severe GFR reduction.
Yes, it's incredible adaptation. This is achieved through the remaining tubules, drastically decreasing the reabsorption of sodium and chloride. They let much more pass through into the urine.
The source quantifies this adaptation. With 75% nephron loss, each surviving nephron must excrete 4 times as much sodium and 4 times the volume of fluid as a normal nephron.
That's the math. And it manages this through a combination of increased GFR and blood flow per nephron due to hypertrophy and vasodilation, and significantly decreased tubular reabsorption.
One key functional consequence of this very high flow rate through the remaining nephrons is something called isostenuria.
Yes, the inability of the kidney to fully concentrate or dilute the urine.
Which one goes first?
The concentrating ability is usually impaired first and more severely. That rapid flow through the collecting ducts just doesn't allow enough time for water reabsorption, even if ADH is present. Plus, the rapid flow through the loop and collecting ducts disrupts the effectiveness of the countercurrent mechanism, reducing that crucial medullary osmotic gradient.
So the maximum concentrating ability declines significantly. The urine osmolarity and specific gravity get stuck closer and closer to that of the glomerular filtrate, around 300 millismol isotonic with plasma.
Exactly. And the diluting ability is also impaired, though typically less so. The rapid flow and high solute load, like urea, in the tubular fluid limit how dilute the urine can become. Minimal urine osmolarity also creeps up towards isotonic.
The source notes that the ability to concentrate urine after water restriction is a sensitive clinical test of renal function, precisely because this ability is lost relatively early in CKD.
It's a good functional measure.
The total clinical picture resulting from kidney failure, characterized by the buildup of urea and other retained substances, is called uremia.
Right. It's the constellation of signs and symptoms. The effects are widespread and depend on the severity of impairment and, importantly, the patient's intake of fluids, protein, electrolytes.
What are the major effects mentioned?
Generalized edema due to water and salt retention.
Metabolic acidosis from failure to excrete hydrogen ions.
High levels of non-protein nitrogens like urea, creatinine, and uric acid. That's called azotemia.
And high concentrations of many other substances the kidney normally clears, like phenols, sulfates, phosphates, potassium, guanidine bases. Lots of stuff builds up.
Water retention and edema can become severe if fluid and salt intake aren't strictly controlled, especially once function drops below 25% of normal.
And even relatively small fluid retention, particularly in ischemic kidney disease, where renin and angiotensin II levels might be high,
Can lead to severe hypertension. The source flat out states that hypertension is almost always present by the time dialysis is needed.
How is it managed?
Managing this hypertension often requires aggressive salt restriction, fluid removal via dialysis, or in specific cases of unilateral ischemic disease, maybe even removing the severely affected kidney to eliminate the source of excessive renin.
As you lose nephrons, that azotemia, the accumulation of non-protein nitrogens, becomes more pronounced, directly reflecting the reduced GFR.
Yeah, those BUN and creatinine levels climb. And acidosis is a constant threat. Your body produces acid daily from metabolism, and if the kidneys can't excrete it, it accumulates. Buffers can handle some, but eventually blood pH drops dangerously low.
Which can be fatal or worsen the cardiac effects of that hyperkalemia we talked about.
Exactly. Anemia is another very common issue in severe CKD.
Why does that happen?
This is primarily due to decreased production of erythropoietin by the damaged kidneys. Erythropoietin, or EPO, is the hormone that stimulates red blood cell production in the bone marrow. Less EPO means fewer red blood cells.
But we have treatments for that now.
Fortunately, yes. Recombinant erythropoietin is available and widely used to treat the anemia of CKD.
Osteomalacia, bone weakening, is also frequent. What causes that?
Two main reasons described. One is decreased production of active vitamin D by the failing kidneys. The kidneys perform the final activation step for vitamin D, which is crucial for absorbing calcium from the gut. Less active vitamin D means less calcium absorbed, less available for bones.
And the second reason?
The rise in serum phosphate levels due to decreased GFR. This high phosphate binds to calcium in the blood, reducing the level of ionized plasma calcium. Low ionized calcium stimulates the parathyroid glands to secrete more parathyroid hormone, PTH.
Leading to secondary hyperparathyroidism.
Exactly. And PTH then causes calcium to be released from the bones to try and normalize blood calcium, leading to bone demineralization over time.
So CKD causes problems getting calcium in and problems keeping calcium in your bones, a real double whammy for bone health.
A very tough situation indeed.
We've touched on it quite a bit, but the relationship between hypertension and kidney disease is so intertwined, the source dedicates specific attention to it. They really feed into each other, accelerating the march towards ESRD.
Yeah, it's a critical connection. It's important to note, though, that not all kidney damage causes hypertension. It's specifically lesions or conditions that impair the kidney's ability to excrete sodium and water that tend to lead to hypertension.
Like decreased GFR or increased tubular reabsorption.
Right. The source examples include increased renal vascular resistance, like renal artery stenosis,
Decreased glomerular filtration coefficient, like in glomerulonephritis.
or excessive tubular reabsorption, perhaps due to too much aldosterone.
When these occur, hypertension often develops because the body needs that higher arterial pressure to force the kidneys to excrete enough sodium and water to match intake.
It's using the mechanism of pressure natriuresis and diuresis. The high pressure resets the balance point.
So the hypertension is essentially the price paid for maintaining fluid and electrolyte balance with impaired kidney function. That's a key concept.
It really is. Another way kidney damage causes hypertension, particularly patchy damage, is through increased renin secretion from ischemic areas of the kidney,
So the sick parts release renin.
leading to angiotensin II formation, which then causes salt and water retention in the non-ischemic, still functioning parts of the kidney, again leading to hypertension. The high BP helps restore overall excretion, but at the cost of systemic pressure elevation.
The source also clarifies that simply losing entire nephrons, if the remaining ones are healthy and salt intake isn't excessive, might cause CKD but not necessarily severe hypertension.
Right. The remaining healthy nephrons can often compensate with only a slight BP increase. But, crucially, add a high-salt diet to that situation, and hypertension can easily develop because those remaining nephrons just can't handle the load without higher pressure.
So effective treatment for hypertension in the context of kidney disease often targets improving the kidney's capacity to excrete sodium and water at a lower pressure.
Exactly. How do we do that?
Well, you either increase GFR, though that's hard pharmacologically, or, more commonly, you decrease tubular reabsorption.
Which brings us back to drugs, medications that block hormonal signals affecting reabsorption, like beta blockers, ACE inhibitors, angiotensin II receptor antagonists.
Drugs that vasodilate kidney vessels to try and increase GFR, like calcium channel blockers.
Or, of course, diuretics, which directly inhibit tubular reabsorption, as we discussed right at the beginning.
It all ties together. Beyond these broad categories of damage, the source also dives into some fascinating specific tubular disorders. These often reveal the critical role of individual transporters or enzymes.
Yeah, these are often hereditary defects affecting specific transport mechanisms in the tubules, though they can also result from damage by toxins or ischemia affecting those specific pathways. Really highlights the specialization within the nephron.
Renal glycosuria is one example mentioned. Here, blood glucose levels are normal.
But there's a defect in the tubular system that reabsorbs glucose, usually the SGLT transporters.
So even with normal blood sugar, glucose ends up in the urine.
Right. It's important to distinguish this from diabetes mellitus, where high blood sugar overwhelms normal transport. Renal glycosuria itself is generally benign.
Aminoaciduria involves failure of amino acid reabsorption. This can be a widespread problem or specific to certain amino acids.
Yes, depends if it's a general defect or a problem with a particular carrier protein. The source mentions essential cystinuria, where cysteine isn't reabsorbed and can form kidney stones.
Subglycinuria.
And beta-aminoisobutyroaciduria, which is noted as common but without major clinical significance.
Renal hypophosphatemia is a failure to reabsorb sufficient phosphate, even when plasma levels are low.
Not an immediate crisis, but chronically low phosphate due to this tubular leak can impair bone calcification, leading to a form of rickets that doesn't respond well to standard vitamin D treatment because the phosphate isn't there.
Renal tubular acidosis is the kidney's inability to secrete adequate hydrogen ions or reabsorb bicarbonate properly.
Right. This leads to excessive loss of bicarbonate in the urine and chronic metabolic acidosis. Can be inherited or caused by various types of tubular injury.
Nephrogenic diabetes insipidus. This sounds like the opposite of the hormone's effect. The renal tubules simply don't respond to ADH antidiuretic hormone.
Exactly. Despite ADH being present, the collecting ducts remain impermeable to water. The result is the excretion of large volumes of very dilute urine. It's dangerous if the person can't access enough water to keep up, leading to rapid dehydration.
Fanconi syndrome is a more generalized defect, primarily affecting reabsorption in the proximal tubules.
Yes, it's like a breakdown of many transport systems there. This leads to increased excretion of lots of substances, amino acids, glucose, phosphate. In severe cases, you also get failure to reabsorb bicarbonate, causing acidosis, increased potassium and calcium excretion, and sometimes even nephrogenic diabetes insipidus.
What causes Fanconi?
Can be hereditary defects, damage from specific toxins or drugs that the proximal tubule normally handles, like heavy metals or certain medications, or sometimes ischemia.
Then there are a couple of rare inherited syndromes linked to specific transporters that we kind of touched on with diuretics. Bartter syndrome.
Right. This is caused by mutations in the genes for the NAK2Cl cotransporter in the thick ascending loop of Henle, or associated ion channels there like Raman K or CLCKB.
So it mimics the effect of chronic loop diuretic use.
Pretty much. Increased excretion of water, sodium, chloride, potassium, and calcium. The salt and water loss causes mild volume depletion, activating the renin-angiotensin-aldosterone system.
And that leads to
The increased aldosterone combined with high tubular flow downstream stimulates potassium and hydrogen secretion in the collecting tubules, leading to low blood potassium, hypokalemia, and metabolic alkalosis.
Gittleman syndrome sounds similar.
It is, but usually less severe. It's an autosomal recessive defect in the thiazide-sensitive NACL cotransporter in the distal tubule, so it mimics chronic thiazide diuretic use.
Similar consequences. Saltwater loss, volume depletion, RAS activation, hypokalemia, alkalosis.
Yes, generally the same pattern, often milder than Bartter.
And the treatment for both Bartter and Gittleman, since the underlying defect is genetic, focuses on replacing the lost salts and potassium.
Primarily, yes. Replace sodium, chloride, potassium. The source also mentioned NSAIDs, which can reduce renin release, and aldosterone antagonists like spironolactone might also help manage the hypokalemia in some cases.
And finally, Little syndrome.
This one's rare, autosomal dominant, caused by mutations in the epithelial sodium channel, the E-Nancy channel, and the distal and collecting tubules, the one targeted by amiloride.
But here, the mutation makes the channel overactive.
Exactly. These mutations cause the E-Nancy channel to be excessively active, leading to increased sodium and water reabsorption in this segment.
Which causes hypertension and metabolic alkalosis.
Yeah.
Sounds like primary aldosteronism.
It does clinically, but the key distinction the source points out is that in Little syndrome, because the sodium retention is happening independently of aldosterone, you have decreased renin, angiotensin II, and aldosterone levels. The hypertension suppresses them.
Whereas in primary aldosteronism, aldosterone itself is high.
Precisely. Fortunately, the source notes Little syndrome can be effectively treated with amiloride or triamterene, which directly block those overactive E-Nancy channels.
So with all these complex ways the kidney can fail, from AKI to CKD to these specific tubular defects, what are the options when function is severely compromised and irreversible?
Well, when kidney function is severely lost, it's life-threatening. The body simply can't remove waste or regulate fluid and electrolytes. The two main life-sustaining options are kidney transplantation or dialysis.
Kidney transplantation, when successful, sounds like the best option, can restore near-normal homeostasis with a single donor kidney.
It generally offers a better quality of life and significantly longer survival compared to long-term dialysis. However, the demand vastly exceeds the supply. The source notes over 100,000 people are on the waiting list in the U.S., with only about 19,000 transplants performed annually. A huge gap.
And transplants aren't without challenges. Recipients require lifelong immunosuppression.
Yes, to prevent rejection of the donor kidney. And that carries risks like increased susceptibility to infection and certain types of cancer, though these risks can often be managed and sometimes reduced over time with careful monitoring and dose adjustments.
The other option is dialysis, using an artificial kidney. This is used chronically for irreversible failure.
Supporting over 475,000 people in the U.S.
And also acutely for AKI, to keep patients alive while hoping for kidney function to recover.
Right. But the source makes it clear that while dialysis is life-saving, it cannot completely normalize body fluid composition or replace all of the kidney's complex functions, like hormone production.
So the health of patients on dialysis is still significantly impaired compared to healthy individuals or successful transplant recipients.
Generally, yes. How does it actually work? The basic principle of hemodialysis involves passing a patient's blood through a device, a dialyzer, which contains thousands of hollow fibers or channels bounded by a semi-permeable membrane, typically cellophane or a synthetic equivalent.
And on the other side of the membrane flows a specially prepared dialyzing fluid, the dialysate.
Exactly. The membrane allows small molecules, water, electrolytes, urea, creatinine to pass through, but retains larger ones like plasma proteins and blood cells.
So unwanted substances that are at high concentration in the patient's uremic blood simply diffuse across the membrane into the dialyzing fluid, where their concentration is kept very low or zero, moving down the concentration gradient.
Correct. The rate of diffusion depends on that concentration gradient, the membrane properties, permeability, surface area, and the contact time. To maximize solute transfer, both blood and dialyzing fluid are pumped through the dialyzer at high flow rates, often hundreds of millimol.
The system uses a relatively small amount of the patient's blood volume outside the body at any given time, maybe 500 milliliters, spread over a large membrane surface area, maybe 0.6 to 2.5 square meters.
And heparin is used to prevent the blood from clotting in the extracorporeal circuit.
Besides diffusion, can fluid be removed too, for patients with edema?
Yes. By applying hydrostatic pressure across the membrane, a process called ultrafiltration or sometimes hemofiltration, when combined with high fluid replacement, you can force excess fluid and dissolved solutes out of the blood.
The composition of that dialyzing fluid, the dialysate, sounds absolutely critical.
It is. It's not just saline. Its concentrations are precisely adjusted to create the necessary gradients for removing specific substances while adding others if needed.
For example,
It typically contains 0-phosphate, urea, urate, sulfate, or creatinine. Since these are all abnormally high in uremic blood, they rapidly diffuse out into the dialysate.
what about electrolytes?
Electrolyte concentrations are adjusted based on the patient's needs. Potassium is often kept low to pull excess potassium out of the patient's blood. Bicarbonate or a precursor like lactate or acetate is usually higher than in normal blood to help correct the patient's metabolic acidosis by diffusing into the blood. Calcium and sodium are adjusted to maintain normal levels.
How effective is it compared to real kidneys?
In terms of clearing small waste products like urea during the session, it's quite effective. The source says an artificial kidney can actually clear urea faster per minute than a pair of healthy normal kidneys, maybe 100 to 225 millimol, versus around 70 millimol for normal kidneys.
But there's a catch.
The limitation is that it's done intermittently, typically 4 for 6-hour sessions 3 times a week. That intermittent nature limits the overall weekly clearance compared to a healthy kidney working 247. Some waste products accumulate between sessions.
And as we mentioned earlier, it doesn't replace other vital kidney functions.
Right, like secreting erythropoietin, so anemia is common unless treated with EPO, or activating vitamin D, or handling larger middle molecules as efficiently. It's a life-sustaining technology, absolutely vital, but a constant reminder of the complexity and elegance we lose when the natural kidneys fail.
Wow. We have truly done a deep dive today, peeling back layers from the clever ways we use drugs to manipulate kidney function.
To the varied battlegrounds where kidney diseases attack specific structures, vessels, glomeruli, tubules, interstitium.
The profound physiological consequences of losing nephron function, the adaptations, the vicious cycle.
And the life-sustaining but challenging realities of treatments like transplantation and dialysis.
It really underscores just how interconnected everything is. How seemingly small details in the source material, like the function of a single transporter like ENAC, or the consequence of immune complexes depositing in a glomerulus, can have such massive systemic implications.
Absolutely. The level of detail matters immensely.
So what does this all mean for you? Having navigated this dense material with us, consider this. Achieving a deep understanding of kidney physiology and pathology, down to this level of specific transporters and disease mechanisms. It isn't just about memorizing facts for an exam.
No, it's about seeing the patterns, the cascades, the complex interplay between different systems, the body's often brilliant adaptations, and its unfortunate vicious cycles when things go wrong.
It's really this level of granular knowledge, the kind emphasized throughout our source material, that unlocks true insight. It lets you understand why certain symptoms occur, how specific treatments work, and potentially how to prevent or better manage these conditions. It's about approaching the material like the specialists do.
It definitely makes you appreciate the sheer brilliance, the constant hard work of these often underappreciated bean-shaped organs, and how much is truly at stake when they're compromised. And perhaps it gives a deeper appreciation for the tools we do have, however imperfect, to support life when that intricate machinery falters.